Hi everyone, my name is Victoria. I'm a nurse practitioner here with Loma Linda Geriatrics, and I just wanted to talk a little bit about how I applied theory to my doctoral project um, this past year. This project was titled Improving Care Transitions and Self-Efficacy Levels in Skilled Nursing Facility Patients and Caregivers. And I want to give you just a little bit more background about the issue at hand. We know that nursing home population is very vulnerable to adverse outcomes. It's a big population. 1 out of 5 hospitalized Medicare patients are discharged to a skilled nursing facility. Typically, those patients are older, they're more frail, and they have a higher morbidity burden. They have really high readmission rates and mortality rates. According to an older study, um, about 37% of those patients went back to the hospital within 90 days, and about 8% of them passed away within 90 days of skilled nursing facility discharge. And of course, besides them being older, frailer, having higher morbidity burden, there's other factors that contribute to these adverse outcomes. There's a lot of care fragmentation. So for example, if a patient went from the hospital to the skilled nursing facility to their home, a lot of times they forget why they were hospitalized in the first place. By the time they get home, they forget which medications were started for them and why. So they may run out of medication and not continue taking them at home, bringing them back to the same situation where they started. There's inadequate communication between care providers. Information is not being passed on from one setting to the next. There's lack of collaboration, limited follow-up, and serious gaps in services. So for example, if they run out of medication, or if home health services weren't delivered in time, they just kind of fall into through the cracks and go back to the hospital. Not to mention that nursing home patients and caregivers are often the only ones carrying the complex healthcare information from one setting to the next. And they often feel overwhelmed with these transitions from hospital to skilled nursing facility back into the community. Nursing home patients are really dependent on healthcare professionals. They usually, when they're first transferred to skilled nursing facility, they're unable to tolerate much activity. And they have some of the lowest levels of self-efficacy across healthcare settings. And just kind of a quick basic definition of self-efficacy, it's that one person's ability to accomplish change or believe that they can accomplish change. So in this case, patients believe that they can maintain their care plan. So those skilled nursing facility patients have some of the lowest self-efficacy levels across care settings. So the main objectives and aims for this project were to assess a skilled nursing facility transitional care quality metrics before and after the intervention, to tailor a self-efficacy education program to those patients and caregivers, prepare them for discharge, to assess for change in their levels of self-efficacy after training. And we were very fortunate to collaborate with our transitional care management team that already exists at Loma Linda, and that is already applying an evidence-based model to the transitions of care. And this was our PICO question. In a skilled nursing facility patients and caregivers, the self-efficacy training and implementation of transitional care model approach to discharge follow-up lead to an increased quality of transitional care from skilled nursing facility to home and improved self-efficacy levels in disease treatment management compared to current practice over the period of 6 months. We're actually going to skip over the literature a little bit, but you can take a look at the slides that are attached to this PowerPoint. But essentially, this intervention was based on a transitional care model by Mary Naylor and her team at University of Pennsylvania. And there were several randomized controlled trials that were successful in showing that this model reduced readmissions after hospital discharge. And just to glance over the components of the model, essentially during the hospitalization, an advanced practice nurse or an RN would check in with the patients and caregivers, enhance care coordination. They would do a lot of goal setting, individual goal setting, extensive management education. And of course, a big bulk of the work would happen after discharge, where the APN would visit the patient within the 24 hours of discharge at their home and continue weekly visits for the first month after discharge, and continue the care coordination, education, symptom management, and of course, one big component was that APN was available via phone for questions or concerns to troubleshoot any issues that the patient was having. So they wouldn't have to go to the ER. They could just call that APN or RN and ask, hey, what do I do? Do I actually need to go to the ER, or can we handle this outpatient? What is the next step for me? There were also several studies about self-management or self-efficacy training programs out there that also showed significant reduction in hospitalization rates for patients with chronic conditions. So the typical components of a chronic disease self-management or self-efficacy program was disease-specific education, symptom management techniques, what role does nutrition play in their illness, how to use medications correctly, how do you deal with the different emotions that come along with those health care changes, how to communicate effectively with your providers during your healthcare encounters, and how to problem solve and make decisions based on the information you have available, or how to look for that information that you may need to make that decision. So for the project, I just wanted to give you a brief overview what happened in the skilled nursing facility when the patients would get discharged from the hospital according to our intervention. So they would be discharged and right away recruited for the project if they qualified and met the inclusion criteria. At that time, typically after if they agreed, we would start doing 1.5 hour weekly education or self-efficacy training sessions with them for the span of 4 to 5 weeks. During that time, the transitional care team would be notified that the patient is recruited. We're doing education, but they would still be kind of in the background, helping to coordinate care, help with scheduling appointments and whatnot, and making sure that they're ready for the patient's discharge when the patient is discharged. Now, and of course, the bulk of the work would happen after patient discharge. So I would perform the first check-in phone call within the 48 hours of nursing home discharge, just seeing how they're doing. Are they missing any vital services? Do they have their medications? And then after that, for the rest of the month, the transitional care nurse and social workers would be following up with the patients weekly, checking in, providing emotional support, checking in on their symptoms, how is everything else going? Are they able to manage their equipment? Maybe that's new to them that they haven't dealt with before. And here comes the theory part. I just wanted to remind us all and myself that nursing theory aims to describe, predict, and explain the phenomenon of nursing. We know that a useful theory makes assumptions about a behavior, health problem, target population, or environment. It is usually logical. It's consistent with everyday observations. It's similar to those in previous successful programs. It's supported by past research in the same area or related ideas. And just looking back at my previous experience with nursing theory, I don't believe we had a ton of exposure to it during our undergraduate years. I mainly remember the two theories, the Benner's novice to expert theory and Newman's systems model. And nonetheless, I still remember how the novice to expert theory would kind of give me hope as I went through my novice years as a bedside nurse, and provided me just a little bit of that encouragement and push to keep going. Don't give up, right? You're going to get better as you gain your expertise in the later years. And as we came into the graduate education, there there's a separate class dedicated to nursing theory altogether. So it was really interesting to learn more about nursing theory. But the main question still remains, how do we apply it to practice, right? So I just want to tell you guys a little bit about the theories that I chose for my project and how they help to guide my practice during the implementation phase of the project. So the first theory that I chose was self-efficacy theory by Bandura, and that one just kind of fell into my lap because it examined the concept of self-efficacy, right? And that's what I was measuring, self-efficacy levels before and after our educational sessions. So just to give a little bit of background, it's based on Albert Bandura's social cognitive theory, and it defines self-efficacy as one's confidence in the ability to achieve change. So if you read this quote at the bottom of the slide, whether you think you can or you think you can't, you're probably right. That defines the theory at its finest. Bandura said that people's motivation is based more on what they believe than what is objectively true. So if the patient believes that they can get stronger, that they can try to walk again, their motivations are going to be way higher than those that are feeling down and don't believe they can achieve that change. And this theory has been a cornerstone in nursing education because self-efficacy levels directly affect patient success in managing their new conditions. And it's important to remember a little equation. The bigger the healthcare change, health condition change, the lower is going to be your self-efficacy level because you're not really familiar with this new situation, a new condition. So hence, there's a higher risk for lower patient success levels. So when we think of how this applies to our nursing home patients, there are multiple situations, right? Multiple diagnoses, stroke, congestive heart failure, COPD, diabetes, right? We had quite a few patients with diabetic foot amputations. So of course, these big changes in mobility based on this new change are going to lead to lower self-efficacy levels and possibly lower success levels as well. So when we talk about self-efficacy theory, there's mainly 4 determinants that lead to high or low self-efficacy levels. And this theory really helped to guide my practice as I was educating the patients during the intervention, right? So of the 4, there's performance outcomes, verbal persuasion, physiological feedback, and vicarious experiences. When we talk about performance outcomes, the best way to take an example of, let's take an example of that patient that unfortunately had to have a foot amputation due to diabetic foot infection. That was their main performance outcome at the time, right? Maybe they unfortunately weren't managing their blood sugars well. They didn't watch their feet close enough for infection, or perhaps the provider they saw wasn't an expert in managing those infections. But typically those happen very quickly and progress rapidly, and the outcomes are pretty poor once the infection is more severe, right? So based on that performance outcome, of course, the patient and the caregivers are going to feel inferior. They're going to have low self-efficacy levels because they just had an amputation. So they're wondering, can I manage my diabetes well ever again, right? Based on how I did this time. Verbal persuasion, and this is where we come in as educators and we say, yes, you unfortunately had this negative experience, this poor outcome, but this is not over, right? This can be just another chance, a new start for you to try to implement those interventions that your providers discussed with you, and this is what you can do this time to prevent another complication, another infection, or just other complications of this condition, right? So being encouraging, persuading these patients that they can be successful is crucial. Physiological feedback is essentially the sensations you get physically as you're going through the change. So if you're nervous or stressed or angry as you're going through this change, of course, your self-efficacy levels are probably going to be lower than if you were calm and positive, and maybe realistic about what is happening. Vicarious experiences have a lot to do with our surroundings, the people that surround our patients, their support network. So, for example, if they're surrounded by people that were successful in managing their conditions, they can imagine themselves, hopefully, that, hey, I can do the same. I can be successful because this person was successful. Why can't I be successful like them? And I just wanted to say that this model is amazing because it applies to any situation, not just our patients, but also to us. When I was a new provider, I felt like this theory came at the right time for me because it helped to improve my own self-efficacy levels as a provider, right? Through trying to improve my performance outcomes, right? How I manage my patients, um, prescribing the right treatment regimens, verbal persuasion, and vicarious experiences. I try to really pay attention to those that were successful around me. Try to have a mentor that would be as encouraging to keep guiding me through this transition, through this change on my way to become a better provider. And of course, physiological feedback. So just trying to have a more positive experience overall. So instead of just being angry and stressed about maybe something I've done wrong, maybe an error that I made, I really tried to keep a positive attitude and get a positive response from my own body about the different changes, the different situations I was going through as I was on my way to becoming a more effective provider. The other theory that kind of fell on my lap was transitions theory by Melise, a middle range theory. And of course, my project had to do with care transitions, and hence the transitions theory. And just a little bit of background. The concept of transitions has always been central to nursing because our interactions mainly revolve around transitions that are situational, developmental, or related to illness. So if you think of yourself as a newborn baby, there was a labor and delivery nurse that probably held you during that transition, and then a maternity nurse that helped to guide your mom through those different changes happening very rapidly, breastfeeding, how to best take care of the baby. And of course, we as bedside nurses have been there for our patients during their illness transitions as well, right? So the theory defines a healthy transition as the one with a personal sense of well-being, mastery of new behaviors, as well as ability to maintain healthy interpersonal relationships. And it's important to remember that the level of success in a transition depends on our previous levels of knowledge and skills, how well we can plan, how well our expectations, our environment, and what is our emotional and physical well-being. And this essentially was the goal for my intervention, was to prepare the patients and caregivers for this big transition from skilled nursing facility to their home. How can we improve your mastery in new behaviors, those nursing skills that you're going to have to perform at home? Another transition, of course, is a role transition. Those patients may have not had to take care of themselves as extensively before, so they're becoming now their own self-care managers, and their caregivers maybe will need to be more involved now, right? They're transitioning into their new role as a caregiver to these patients. So that was the overall goal, is to prepare the patients and caregivers well for those important care transitions. We all have heard at least several times at this point about the Iowa model of evidence-based practice. And looking back, this model provided great structure to my project because, of course, we worked on establishing a trigger issue, which in my case was poor care transitions for my patients and caregivers. We had to decide whether it was priority or not. We had to start a project team, conduct a literature review to determine the best practice for this situation, design an intervention, and discuss how we can adopt this into practice. And of course, the last step, to disseminate the findings of our study. So just to summarize it all again, we know that a useful theory makes assumptions about a behavior, health problem, target population, or environment. So in my case, my theories made assumptions about transitions of care and self-efficacy. Right? A useful theory is logical, consistent with everyday observations. It's similar to those used in previous successful programs. It's supported by past research in the same area or related ideas. So in my case, the theories that I chose were the guiding star that led me through my education encounters. These theories gave me hope that I'm not the pioneer in the field. There were others that were helping their patients through transitions of care, and helped others to improve their self-efficacy levels. So it was really useful to have that structure and theoretical support. So I really encourage you guys to consider investing time in learning more about these different theories in nursing and other fields, to develop your own personal practice philosophy, your own practice style, because the more you understand patient experiences that are described by those theories, the more effectively you're going to be able to guide them through these changes. And this is really going to make you a better provider. And this is one of the ways that theory can be applied to practice. Thank you guys for watching, and I hope you guys have a good, successful rest of the year and have a successful project implementation coming up ahead.